Hello, Achievers. Welcome to Team MDS. Myself, Dr. Vikram. Today we are here to discuss about the pulpotomy. See, pulpotomy means the removal of kernel pulp and leaving the radicular pulp is the main major concept that is involved. And the definitions that was given by Finn is a complete removal of kernel portion of the uh, dental pulp followed by placement of a suitable dressing or medicament that promotes the healing and preserves the vitality of the radicular pulp or radicular, thereby the vitality of the tooth is maintained. And whereas American Academy of Pediatric Dentistry in 1998 they gave it's an amputation of affected and infected kernel portion of the dental pulp, preserving the vitality and function of the remaining pulp of the radicular pulp. See, the definitions are not important for the NEET exam, but at the same time they are required for your understanding of the topic. The name itself, the definition itself, is explaining everything, right? Affected, infected, kernel portion of the dental pulp is removed, and thereby and afterwards they will be there is a preservation of the radicular pulp. That is, only the kernel portion of the pulp is removed and the radicular pulp is preserved. So thereby it is a normal vitality of the tooth is maintained. This is the definition itself giving the what it is actually. The rationally, it is a healthy radicular pulp is healthy and capable of healing after the surgical amputation of the infected kernel pulp, preserves the vitality of the radicular pulp and maintains the tooth in the physiological condition. And it is also one of the most commonly involved procedure for an apexogenesis. That is like in order to preserve the radicular pulp so that it will form the root portion that is not formed can be completed by its own. That is like it is a normal tooth. For an open apex condition also we can indicate the pulpotomy so that the radicular pulp is preserved, thereby helping in the formation of the root which is not completed can be completed over a period of time. Coming to the advantages, that is objectives, is a removal of inflamed and infected kernel portion pulp at the site of exposure, thus preserving the vitality of the radicular pulp and allowing it to heal and maintain the teeth in the dental arch, which is a natural space maintainer. Acts in a natural space maintenance. Indications of pulpotomy is the mechanical pulp exposure in the primary tooth. That is like while doing the cavity preparation at sometimes. If at all we have undergone very to high depth and causes exposure of the pulp, thereafter we will be removing the kernel pulp that is present in the tooth. And history of only spontaneous pain emerge from the exposure site, bright red and can be controlled. Absence of that is like abscess and fistula, no interradicular bone loss or no periapical lesions or any radiolucency seen or any kind of like a widening of PDL fibers or anything doesn't happen, then we can go for it. And at least two-thirds of the root length still present to ensure the reasonable functional life and end permanent tooth with a vital exposure pulp and incompletely formed apices. See, it is one of the treatment that that is done. If at all we do the pulpotomy so that to form the our natural teeth, say suppose a 8-year-old child has an incident of any kind of damage to the teeth, and there is an open apex that is present. At the same time, it's a permanent tooth, right? So we will be leaving only removing only the kernel portion of the pulp. So that is the treatment that is involved in the apexogenesis. Whereas in the primary teeth, only the if at all we the kernel pulp that is extended exposed or due to any kind of infections, then it is called as pulpotomy. Actually, pulpotomy and apexogenesis are not somewhat like different, but they are at the same time they are both interlinking to each other. Contraindication of pulpotomy, that is persistent toothache, tenderness of percussion, root resorption more than one-third of the root length. That is like if at all root resorption is much more faster, that is more than one-third of the root, then we cannot indicate for the pulpotomy. And large carious lesions with non-restorable crown also cannot be indicated. Highly viscous and sluggish hemorrhage from the canal orifice and Medical contraindications like heart ischemia or immunocompromised or swelling of fistula or external or internal resorptions and pathological mobility or calcification of the pulp, then we have to, if at all there is a calcification of pulp, then we have to go for the pulpectomy procedures in the primary teeth or root canal therapy in the permanent tooth. And vital pulpotomy technique. There are three techniques: devitalization, preservation, and regeneration. Devitalization, it is a single sitting technique. Pharmacology can be used, or electrosurgery or laser with a NDYG can be used. And two stage is the formaldehyde, which means two stage technique, and gysotriopase, that is also two stage technique. Whereas for the preservation, it is glutaraldehyde, ferric sulfate, MTA, and calcium hydroxide. For the regeneration, bone morphogenetic proteins, and for the non-vital pulpotomy. Till now, we have discussed about the vital pulpotomy, that is like devitalization, preservation, and regeneration. Whereas non-vital pulpotomy is, that means the mortal, then the beechwood cresol or formocresol can be used. Coming to the like a technique of general what is involved in the formocresol pulpotomy, that is the most commonly asked questions like. So that's why we should know about the formocresol pulpotomy. You might have studied in your final exam, but just I'm just going through it briefly. First thing is you should be the anesthesia, then isolate with a rubber dam if possible for the child, and remove all the caries with a high speed burr, and then followed by dental roof is removed. The coronal portion is exposed, the coronal pulp is removed, removed, then the cotton pellet is placed over the pulp stumps to achieve the hemostasis. That means what are the orifices that are exposed are over that area we will place our cotton pellet so that it becomes dry, and then using cotton pellet apply the diluted formocresol to the pulp for 4 minutes. Then place a small dry pellet over this area to avoid the contact of the tissues with the formocresol and remove the cotton pellets. It is like a, see, first cotton is the to prevent the like a to with the help of formaldehyde, and second cotton is a dry cotton just placed above the tissues to avoid the contact of the tissues with the, it is like a formocresol should not come in contact with the oral tissues, right? So that's why we will be placing in a another cotton over the formocresol cotton, and place the ZY cement in the pulp chamber. So first we have to remove the cotton pellet, and we have to see there is a devitalization of the radicular pulp over that particular area, that is exposed area, that is seen, that is like brownish discoloration should be observed. Then only we can go with an with a permanent restoration if patient is asymptomatic, and places stainless steel crown. If at all the patient is asymptomatic even that time, then you have to go within a pulpectomy procedures. And modified formocresol pulpotomy. This technique was used by Trask in young permanent molars that have been retained for a short period of time. And this technique is identical to that described for the primary teeth, except that formocresol pellet is sealed permanently in the tooth. That is like formocresol is placed, pellet is placed, over that the restoration is placed, and over that if at all there is no pain after 1 to 2 weeks, then the cap is placed. That means the cotton pellet with the formocresol is in the patient mouth itself only. Indications are there is evidence of sluggish bleeding at amputation site that is difficult to control and pus in the chamber, but none are the amputation sites. And there is thickening of PDL and history of pain is present. Contraindications are non-restorable tooth and tooth with a necrotic pulp. It has to go with a pulpectomy. So, yeah. Whether two-visit diabeticization pulpotomy. This is a two-stage procedure involving the use of paraformaldehyde to fix the entire kernel pulp and radicular pulp. That is like an entire kernel pulp and radicular pulp are fixed in 2 visits. That is, for the first visit, we give anesthesia, isolate, then preparation of the cavity, deep case removal, enlarge the exposure site with a round burr, and then incorporate the paraformaldehyde. Paraformaldehyde is been a paste is incorporated in a pellet and placed over the pulp exposure, and then they seal the tooth for 1 to 2 weeks so that the formaldehyde gas that is liberated from the paraformaldehyde enters the kernel and radicula pulp, thereby fixing the tissues. And then in the second visit, what we'll be doing is pulpotomy is carried out under the local anesthesia and remove the cotton pellet and deroof the pulp chamber, clean the cavity with the saline and dry with the cotton pellet, and pulp chamber filled with a antiseptic paste, and tooth is restored. That is, see, we are placing the we are doing the pulpotomy in a second visit. We are only doing with the help of paraformaldehyde. See, paraformaldehyde will do an devitalization by releasing of the gases in the form of formaldehyde. It is like it will disintegrate, paraformaldehyde will disintegrate into the formaldehyde, and which will be entered into the kernel pulp, and thereafter it will cause a devitalization of the pulp. So that makes the treatment as in a much more painless, very less painful. At the same time, the entire pulp is devitalized. The kernel pulp is devitalized, so it can be removed easily instead of the vital pulp that was removed under the normal general pharmacological pulpotomy. Here, what we will be doing is we will place a paraformaldehyde in the first visit, and the second visit we will be doing the pulpotomy of the kernel pulp, which is devitalized by releasing of the gases from the paraformaldehyde. And the materials that are used for the two visit pulpotomy are glycipase and Islex paraformaldehyde and paraform devitalizing paste. Laser pulpotomy. The use of lasers in the pulpotomy was based on their ability of rapid control of bleeding and coagulation. In 1985, Epimara reported that the effects of a NDYG laser on the wound healing of amputated parts using the NDYG laser at 20 Hz, placing the intermediate restorative material, that is IRM paste, and many other materials. Authors have also compared the various lasers in the environmental use, and they have found that carbon dioxide or NDYG or diode lasers are very beneficial. And the procedure is that first any treatment made anesthetize first, then apply rubber dam, then remove all the caries with the burrs and open the pulp chamber, remove the coronal pulp and with the help of spoon excavators. Then use the diode laser that is of about 8-10 nanometers of wavelength. It's at a speed of 3 watts of power in a continuous wave. Continuous wave means it appears like it appears like this continuous wave. There are different type of lasers, that is like continuous, uh, continuously irregular, like incontinuous or discontinuous kind of wave, lasers also occurs. And applied till the directly apply the beam on the amputated pulp stumps with all the necessary laser precautions. That is, patient's eyewear should be given. We should also wear an eyewear, and also assistant who is assisting should also wear the eyewear and apply till the ablation and hemostasis is achieved, but not exceeding more than 2 to 3 minutes. Place the IRM paste and then we can restore it with a stainless steel crown. Simple procedure, right? With the help of lasers, it is making a very easy procedure. Even in the that is like a flap surgery is also like previously we used to do the flap surgery of one quadrant 1 week, next quadrant another week, and a third quadrant in the third week, and fourth quadrant in the fourth week, like that. But now the entire treatment can be done in just 1.5 hours with the help of lasers. Lasers are making the process very much easily, especially even in the that is like a bloodless surgery and electrosurgical pulpotomy. Mark was the first US dentist routinely to perform the electrosurgical pulpotomies in 1993 with a success rate of 99% for the primary molars. The procedure is anesthesia, isolation, caries removal with a large round burr followed by sterile cotton pellet that are placed in the contact with the pulp, and pressure is applied to obtain the hemostasis. The, the Fracta plus 797 is get at a speed of 40 power, and the 705 AA. Dental electrode is used to deliver the electric arc, and the cotton pellet is quickly removed and electrode is placed 1 to 2 mm above the pulpal stump. Electric arc is allowed to bridge the gap to the pulpal stump for 1 second, followed by cool down period of 5 seconds. Then the procedure is properly performed and the pulpal stumps appear dry and completely blackened. Then we can go with a placement of ZOE cement over it. That is, see, the treatment was done perfectly or not can be identified if at all it becomes completely blackened at the pulpal stumps. Quex pulpotomy. This is also one of the important things that you have to remember few points. That is like calcium hydroxide pulpotomy. This was done in the egg permanent partial pulpotomy, and this was carried by Majare and Quick in 1978, indicated in young permanent teeth where the pulp is exposed by mechanical or bacterial means and the remaining radicular tissue is judged vital by clinical and radiographic criteria, whereas the root closure is not complete. Here, that is nothing but apexogenesis. Here, what we'll be doing is young permanent teeth means it's not in a young child. It actually means the tooth that has been erupted into the oral cavity without any without completion of root formation. That should be understood. Not like a young pulp means not a young age child. Coming to the mortal pulpotomy, it is also called as non-vital pulpotomy. Ideally, non-vital tooth should be treated by pulpectomy, but sometimes it is impracticable due to the non-negotiable root canals and limited patient cooperation, and mortal pulpotomy is indicated for such patients. Because see, sometimes what happens is the patients will be very hysterical, like they don't wear properly. As we have to do the BMP and obturation is actually we should be done for the pulpectomy procedures, whereas we cannot do that in a patient who is completely hysterical. So what we will be doing is just remove the pulp, whatever the coronal portion of the pulp that is exposed, means the coronal portion is removed, and then with the help of like this procedure makes it very less painful to the patient, so thereby the patient becomes cooperative. Necrotic coronal pulp is removed, pulp chamber is irrigated with saline and dry cotton peel is placed. Infected radicular pulp is treated with a strong antiseptic solution like benchwood cresol and seal the cavity with the temporary cement for 1 to 2 weeks. Then after 1 to 2 weeks period has been completed, then we will call for the second appointment. If the tooth is asymptomatic, the pulp chamber is filled with an antiseptic paste and the tooth then restored with a stainless steel crown. Nothing much. It's just like an uh, uh, placement of this benchwood cresol and also antiseptic paste so that there are no further infection that occurs. Current concepts in pulpotomy, that is Portland cement and mineral trioxide cement, that is a MTA. MTA is one of the major important topics that can going to be asked, like because see MTA, calcium hydroxide, biodentin are the majorly used materials in the endodontic of the periodontic, that is a pedo endodontics in a pedo department. Portland cement is not as much important, but we just have to know a little bit about it. That is like a pulpotomies with a Portland cement as the medicament in human primary molars were performed by Conti, and MTA and Portland cement as in the same clinical, biological, and mechanical characteristics. So the only difference was bismuth oxide was added to the MTA, which is why bismuth oxide is added, because it provides a radio opacity. That is like whenever you take an X-ray, it becomes it can be seen as a radio opaque material. Mineral trioxide aggregate. It was described the physical and chemical properties of MTA in 1995 by the Thorabinjan, and it is an ash color powder made primarily of the hydrophilic particles of the tricalcium aluminate, tricalcium silicate, silicate oxide, tricalcium oxide, and bismuth oxide. The hydration of the powder results in a colloidal gel composed of calcium oxide crystals in an amorphous structure. This gel solidifies into a hard structure in less than 3 hours, and it has a compressive strength that is equal to the ZOE with a polymer reinforcement material, that is like IRM. It is equivalent to the IRM. And the properties of the MDA is that its first thing is biocompatible, that's why we are using an AMN body, and its sealing ability is better than the amalgam or ZOE. It has an initial pH of 10, and then it sets to the pH of 12.5. Setting time of cement is 4 hours. That is like by the end of 4 hours it will be almost very hard, and the compressive strength is 70 megapascals, which is comparable to the IRM, and low cytotoxicity. That is like if at all it is extended beyond the apex, sometimes that is called as a over obturation kind of thing. Then also there is no problem and will be occurred. And the MTA has demonstrated the ability to induce R tissue formation in the pulpal tissue, and it promotes the rapid cell growth. The application procedure is apply the rubber dam first thing, then remove the caries with the help of burr, then pulp chamber, that is open the pulp chamber, remove the kernel pulp with the help of a spoon excavators, and use the moistened cotton pellets and moderate pressure achieve the pulpal hemostasis. Apply MDA paste to cover the exposed radicular pulp surface and a margin of less than 1 mm beyond the pulpal dental interface, and apply wet cotton to help an MDA set. Then seal with the ZOE, that is IRM also can be used, and restore within a stainless steel crown. That is like, see, MDA paste is used to cover the exposed radicular pulp. See, in the apexification also we can use MDA. That is like, if at all there is an open pulp, that is like open apex, and the tooth is non-vital, then we will be going with the help of MDA, which will form an hard calcific tissues, and thereby forming an radio apex of the immature tooth or open apex tooth. Similarly, here it is placed over the pulpal stump areas. Here it will cause an formation of hard tissue. Over it, we will be placing a ZOE cement followed by stainless steel crown. Simple procedures. These are not difficult, and at the same time, no one is going to ask you the entire flowchart of it. But actually, you should know it's the same, because like whenever the question comes like when is the MTA is placed, is the MTA is first the ZY should be placed over it, MTA should be placed, or MTA should be placed over it, ZY should be placed. Like this, they can ask you some kind of like a tricky questions. They feel like that, but sometimes they could ask you like this kind of questions. So you should be able to, MTA should be placed over the pulpal stump areas, then over it after once it initial set occur, then ZY cement is placed over it, stainless steel crown can be given. Nano-hydroxyapatite and bone morphogenic proteins appear to be biocompatible and produce no pulpal reactions. Studies only done in the animals, and no human trials are not done yet. So that's why we'll not be discussing more about it, because like both morphogenic proteins and all are like a completely like controversial, and also like many theories, many articles, many researchers publications are going in the different colleges in India and also in the various other countries. We have to see like if at all they comes in some kind of like results with it. And calcium enriched mixture that was given by Malik et al. Compare the calcium enriched mixture and MTA over the pulpal resins as biomaterials in a vital pulpotomies of the carious primary, and concluded that it can be used as a similar properties similar to the MTA. So calcium enriched mixture can also be used for, is what they gave by the Malik et al. Whereas alien serum oil, Mohammed et al. Compared the clinical and radiographic effects of this alien sativum and those of the pharmacrazole in vital and pulpotomy in the primary teeth. And they discovered that the good healing potential was present and leaving the remaining pulpal tissue functioning and healthy. Alien sativum, I guess it is an oil that is obtained from an onion. That is alien sativum might be, let me find. Alien sativa means in a garlic. That is like a garlic oil was extracted, and from it they have done this research. They are just like see these kind of questions they can ask you in the aims like what is the research that is conducted by the, like no one will ask you the scientist name. They will ask you like alien, can alien sedatum can be oil can be used as a pulpotomy material or not? Yes, they can be used because like it is similar to the property similar to the MTA. So thereby we can use it. But still we have to do further research like no other inflammations that occur over a period of time. If everything is clear, then we can start utilizing in the patients. Like see the main profit that comes is this oil, this alien sedatum that is nothing but garlic oil is not very expensive, right? So thereby our treatment process will also will become affordable to the patients. That is what the researchers are intended to. This MTA is in a somewhat like in a material which is an artificially made. We have to make that is like a, we have to extract the calcium, tricalcium should be done, reactions all should be manufactured. Makes somewhat expensive. Whereas already naturally available materials can be used from which the oils can be extracted. These kind of researches are going on in different things. We have to see like the next 20 years like is going to be something like a materials whichever whatever there is like a very affordable to the every patient is what the intended to be. Not all the researches are done for the money, but like even I can say that in my PG that is like what we say that introduction classes that was conducted by PhD staff people, they have said that like they found a research where the curry leaves as an antimicrobial properties. So those people has done and research on this curry leaves because curry leaves is nothing but karapaku. That is like a so it is frequently available in all the areas of the country, right? So they have extracted that material and made a juice oil from it, and they have used it as a mouthwash gel, and they found that yes, it is also has a very good antimicrobial property. So thereby the cost of this mouthwash gel will be decreased. That is like previously like chlorhexidine and triclosan. These all are very expensive, somewhat expensive to the patient, right? So that's why like with the use of this curry leaves, everyone can use this for their benefits. So thereby the antimicrobial property can be increased. So teeth affecting rate will be decreased. These kind of researchers are conducting, and we have to see like what happens. Enamel matrix derivative as a pulpotomy agent is obtained from embryonic enamel as an amelogenin has been demonstrated in vitro to be capable of stimulating the periodontal ligament cells proliferation sooner when compared to the gingival fibroblast and bone cells. That is like see, uh, ameloblast and odontoblast are together functions, right? Ameloblast functions and odontoblast functions are both interlinked. So they are now identifying these proteins that is like amelogenin proteins which are released should be also might have an ability to induce the periodontal fiber is what their research is about, and the ability of the EMD to facilitate the regenerative process in the mesenchymal tissues is well established, and the introduce this induced process actually mimics the parts of normal ontogenesis, and it is believed that these proteins participate in the reciprocal ectodermal mesenchymal signaling that control the pattern and these processes. And based on this observation, they have suggested that amelogenin participates in the differentiation of the odontoblast, thereby resulting in the formation of predentin formation. Once the predentin is formed, thereafter the entire dentin structure will be started forming. An endogen gel that was been successfully employed for the pulpotomies in an uninfected teeth in animal studies. And also, the EMD components act as a signal for the induction of mesenchymal cells. The procedure is not something different. That is like a kernel pulp is removed, and then the pulp chamber is irradiated with the normal saline. Then hemorrhage was controlled with a sterile cotton. The teeth were acid etched with about 35% of phosphoric acid gel and primed. That is like the bonding agent. And the cotton pellet was removed, and the amputated pulpal stump areas was covered with an endogen gel of a 0.3 to 0.11 syringe, and the light cured glass enamel cement was applied to as a restorative material. That is like, see, we have done a bonding, we have done etching bonding. So the light cure material should be used as a bonding, right? That is the basic, simple logic. And propofol is platelet-rich plasma and anchor-ferried blood stoppers and pulpototic. These are also another material that was introduced by various scientists. Like, not all this, everything is not completely important. The only thing is you should remember the materials and what is the main function of this. This PRP is nothing but a autologous modification of the fibrin obtained during the autologous blood and used to further growth of the tissues and adjoining it. Pulpotic, and these are other materials. Calcium phosphate cement, which has a property that is similar to the biocompatibility, osteoconductivity, and moldability. This is one of the properties that are present in this calcium phosphate cement. Coming to the biodentin, biodentin is one of the major important point you can remember. That is like, see, pediatric endodontics now can be safely considered as a munificent entity which has changed the prognosis of many cases which were once considered as an unsavable. A new bioactive calcium silicate based cement has been recently launched in the dental market as a dental substitute. These are aids in the penetration of open dental tubules to provide the crystallization and interlocking with the dentin and provide the mechanical properties. Biodentin has been formulated using the MTA based cement technology and hence the claims improvement of some of the properties such as physical qualities and handling, including its other wide range of applications like endodontic repair and pulp capping and restorative dentistry. Setting time and porosity and characteristic of MTA and biodentin. That is like a see, MTA has a setting time, initial setting time of 70 minutes, whereas biodentin has a 6 minutes. That is like it is becoming. That is what the researchers over done over a period of time are now being employed to save the time and same time save the cost of the patient and the clinicians. So that is what the researchers are developing. See, MTA, which was previously used, now the biodentin is replacing the MTA. Why? Why? Because it has a less setting time and a less final setting time. So thereby the patient's time is saved. And even during that time, the another dentist can do the treatment on another patient. So why? We'll also be like saving our time. So time is money, money is time, nothing other. They are both are interlinked to each other, so, right? And at the same time, composition of biodentin, what it is made up of: tricalcium silicate, dicalcium silicate, zirconium oxide, and iron oxide. Here to very traces level. Coming to the use of the biodentin, that is, it has been reported to be successful in certain unconventional circumstances, which include the pulpotomy, and after several days of traumatic pulp exposure, single visit apexification, and massive resorptive lesions with the multiple perforations combined with the periodontal lesion and incomplete vertical root fracture can be done. The procedure, what is the procedure? Same, everything is first anesthetize, give the block, everything that is same. After that, once the hemostasis has been achieved, then biodentin is mixed according to the manufacturer instructions and applied. The biodentin capsule is struck gently on the solid surface and then mix the powder inside. That is like inside the cavity. And mix the 5 droplets of liquid for a 30 seconds using a titurator. And the biodentin mixture is condensed to the pulp stumps using an amalgam carrier and moistened the that is a cotton pellet is placed and the cavity is filled with a biodentin after the waiting time of 9 to 12 minutes has occurred. That is like initial setting time of 6 minutes and final setting time is of 10 minutes, right? So, on a safe side, we will be taking care of about 12 minutes and restored by the stainless steel crown then.